So we're going to take a look at respiratory acidosis, and one thing that we need to remember is that when respiratory acidosis, that respiratory opposite, so when our pH indicates acidosis, that means that the pH is going to be less than that 7.35, then our PCO2, which represents respiratory, is going to be high. So our pH is low, our PCO2, or our carbon dioxide, is going to be high. So as we go through this, we're going to look at acute, chronic, some ways that we treat it, and things that we can assess our patients for as well. So let's just start off by taking a look at this circle. So basically we know that homeostasis, that's when we have that normal pH. So we've got 7.35 to 7.45. Any disruption within this respiratory system that is maintaining our pH means that we're going to start retaining that CO2. And when we retain that CO2, our ABGs, our PCO2 level, is going to increase, and it's going to be above 45. And this is because there's an increase in our hydrogens. And so those hydrogens, remember, that's what forms that carbonic acid. That's what drives our pH down. So as you can see, it should be represented by our pH going down when there's this disruption. And what results is we have respiratory acidosis because we've had this increase in hydrogen, which then forms that carbonic acid, and our pH drops below that 7.35. Now, immediately when we have this respiratory acidosis, our buffering systems are going to be activated. They are going to start trying to compensate for this lowered pH. So any of our buffering, our normal quick-acting buffers, are going to start accepting those hydrogens, those extra hydrogens that are in the blood. Our kidneys are going to start to compensate by trying to get rid of the extra hydrogen. They're going to start excreting hydrogen in your urine, and they're going to start producing that bicarb to create that balance for that ratio of that 20:1, like we talked about in the first lecture. And then eventually our pH will hopefully return to normal as that respiratory correction happens, or that compensation happens, because our respiratory center is going to be activated so that our respirations increase, we're blowing off more of the CO2, and our depth is increasing, creating better oxygen or gas exchange, and this will help return our pH to that normal range, back to the circle where we are now at homeostasis. Now, in any of these circles, there could be a breakdown, and this is where medical treatment is going to be necessary, because say that our buffering system cannot keep up with it, our renal system, for whatever, may have failure, it can't keep up with it, our respiratory center, or our in our brain, we're not able to activate the respiratory center to increase those respirations. That can all cause problems, and we have to have medical treatment in order to fix some of those conditions. So let's start looking at just respiratory acidosis altogether and really understand again what's going on. Hopefully that circle kind of helped you, but we'll just hit it this way as well. Respiratory acidosis is going to be caused when we have an excess of dissolved carbon dioxide that forms this carbonic acid, because remember, carbon dioxide, when it's dissolved in water, it forms that carbonic acid. Now, we can have acute or chronic lung conditions that can increase the risk for respiratory acidosis. Also, anything that's going to suppress or interfere with ventilation and cause this hypoventilation is going to be a risk. So things like a drug overdose, opioid use, sedatives, anything that's going to sedate a patient, neuromuscular diseases, because they may be affecting how well the lungs are actually ventilating. They cause what is called hypoxemia, which means that we end up with low oxygen, and this is usually going to be associated with that hypoventilation, because our lungs are not able to exchange that CO2 for oxygen when we are breathing. So our red blood cells don't actually get oxygenated, resulting in this hypoxemia. So we may have respiratory failure. Now, our kidneys, like we talked about a minute ago, are going to try to compensate. They are going to start conserving as well as making bicarb, and they're going to start excreting those extra hydrogens in the urine. So we will see all of these kind of play in, and we can actually, when we start assessing our ABGs, we can see these levels changing based on how well our body is compensating those things. So let's talk a little bit more about acute versus chronic lung disease. So with acute respiratory acidosis, we need to know that this is going to be a sudden onset, something like a chest trauma, cardiac arrest, maybe ingestion of some kind of foreign body that's actually causing an obstruction, maybe acute pneumonia. We've got drug overdose or increased sedative use or improper sedative use. Anything that is going to cause this sudden hypoventilation. What that's going to do is it's going to cause the pH to fall quickly, and because it was a quick onset, the pH falls quickly, and the buffering systems cannot keep up with the excess hydrogen that is now being held in the body. Because remember that our renal system can take hours to days to actually be effective and to kick in and correct that pH. So this acute onset can cause that major drop. So now remember that because we have this increase in carbon dioxide, our kidneys can't kick in fast enough to correct this pH. We have all this extra carbon dioxide in our body. And carbon dioxide can actually cross the blood-brain barrier, and it can start to affect the neurological function of a patient. So other things that are going to happen is the blood vessels are going to actually start to dilate, which can eventually increase that intracranial pressure if the condition is not reversed. So acute is usually going to require immediate attention in an emergency department. It may require your patient to stay in the ICU while they are trying to restore ventilation and administer oxygen. So we're going to see this drop in pH. We may see a decrease in their level of consciousness because of that carbon dioxide crossing the blood-brain barrier. We have blurred vision and headache, and this can be due to some of the intracranial pressure that we may see. They may have some flushed skin, and that's from that vasodilation, and they potentially could even end up with cardiac arrest. Now, chronic respiratory acidosis is usually a much slower progression of acidosis, and it's typically caused by some type of long-term disease process, something like COPD, asthma, cystic fibrosis, or even multiple sclerosis. And the PCO2 is going to increase, but because it doesn't increase drastically, our other buffering systems can kind of kick in and have a little bit longer to keep that pH within normal range or to keep it closer to normal range. So, and this is because they actually have that longer period to actually work because the carbon dioxide level gradually increases. So like we talked about, the renal system, it doesn't usually kick in for hours to days. So if it's a gradual progression of a disease process, the kidneys can actually kick in because they have that time period, they have those hours, and they have those days to actually start buffering some of this acid. So they still are going to retain that bicarb to help keep the pH up. They still may be getting rid of the hydrogen, but because it was a slower progression, they actually are more effective. And so what we're going to see is that our pH is actually going to be a little bit closer to that normal range, and we may even see that our bicarb is going to be higher when it comes to our ABGs. So, and this is because, again, that disease process was a little bit slower. Now, something else that we need to remember is because the disease process is slower, our respiratory center in our brain actually becomes less sensitive to changes in that PCO2. So normally when we have changes in that PCO2, our brain is triggered to try to increase those respiratory rate. Remember, go back to that circle. It's going to increase the rate and the depth. But if it is a slower progression, like in chronic diseases, it becomes less sensitive to changes in that PCO2. And so no longer does it change because the PCO2 changes. So our respiratory rate's not going to change because of that. It's actually going to be stimulated or triggered by our PO2. So that's what's going to drive a person with chronic respiratory acidosis to actually breathe. So if our PO2 increases too much, say we're giving that patient too much of a supplemental oxygen, then the patient may actually lose the drive to breathe, because as that PO2 lowers, that's what is triggering the respiratory center to increase their respirations, to increase that oxygen gas exchange. So some things that we may see in those patients, we've got that weakness. They may have just a dull headache. We still may see impaired memory, and that's due to that carbon dioxide. We may see that personality or mood changes, and remember, carbon dioxide can cross that blood-brain barrier, and we may see sleep disturbances in these patients. So, key thing to remember is going to be we've got neurological changes with these acidosis on both acute and chronic, so we need to be watching for that. We usually have some sort of drop in pH, whether it's a sudden drop or a slow drop. And our kidneys are going to try and buffer both of these, but it's not going to work as well in acute because of the fast drop. But in chronic, those kidneys are going to retain that bicarb to actually help bring that pH closer to a normal range. Now, ways that we're going to actually look at diagnosing whether it's acute or chronic, we're going to look at those ABGs. So remember, when we are acidotic, our pH is going to be less than 7.35. Our PCO2 is going to be greater than 45. That's that Rome. Respiratory means that these two things are going to be opposite. So our pH is low, our carbon dioxide is going to be high. Typically with an acute, our bicarb is going to be normal because the kidneys have not had time, that renal system has not had time to actually kick in and start buffering. So with an acute, we're going to have a low pH, a high CO2, and a normal bicarb. So that's going to be what we see with our acute patients. Now with chronic respiratory acidosis, the pH may be closer to normal. So if it's not within normal range, it's going to be barely lower than normal range, and that's because that bicarb has kicked in. It's trying to move it closer to that 7.35. But what we're going to see is that our PCO2 is going to be high and our bicarb is going to be high because the renal system started buffering. So with our chronic respiratory acidosis, we see... Okay, sorry. Slight interruption there. So we were talking about the chronic respiratory acidosis. So our pH is going to be normal or closer to normal with our chronic respiratory acidosis. Our PCO2 and our bicarb are going to both be elevated. So the PCO2 will be greater than 45 and the bicarb will be greater than 26. Now, with chronic respiratory acidosis, these serum electrolytes may also indicate some hypochloremia or low chloride. And this is because the renal system is getting rid of chloride over time during that compensation. We also may see chest x-rays done. This is going to help identify any kind of lung diseases going on, and this can help us determine whether or not it is acute or chronic. So if your patient's got pneumonia, we can see that on a chest x-ray. But if they have chronic obstructive pulmonary disease, we could also see that on a chest x-ray. We also can see the progression of some of those chronic disease processes. Our sputum cultures are also going to help us identify underlying disease processes, whether it's pneumonia, and knowing which antibiotics we may need to be giving for those. And then we've got pulmonary function tests that are typically going to be done with the chronic lung diseases, or if that is suspected, and they can help aid in the progression of the assessing the progression of the chronic lung disease, as well as diagnosing that. Now, how are we going to treat our patients? So the goal of our treatment is to improve ventilation and to improve gas exchange with respiratory acidosis. So this is going to include our bronchodilators, or our breathing treatments that are going to actually open up the airways to improve that gas exchange, so we can get that CO2 off and we can get that oxygen in. Antibiotics will be given, especially if we've got acute pneumonia or some sort of respiratory infection. We're going to make sure that our patients are staying hydrated, and what this does is help keep those pulmonary secretions moist so that we can actually expel them easier, whether that's through coughing or pulmonary percussion. Any of those things, we want those secretions to be moist, especially if our patient is going to be ventilated and we may have to actually suction them through that ventilation. We want it to be moist so that it actually will come out a little bit easier. And then we need to remember oxygenation. So with acute respiratory acidosis, we know that our patient could be hypoxemic, which means they have low oxygen. So our main focus is going to be reverse that hypoxemia. So whether or not we're having to put our patients on a ventilator to help with that oxygenation, or maybe we are having to give them a greater amount of oxygen because of this acidosis that caused the hypoxemia. But with chronic respiratory acidosis, that is not the case. We're going to give them continuous oxidation, yes. So they're going to have continuous oxygen, but we're going to do it at a much lower rate. And remember, that's because the oxygen is what is driving their desire to breathe. So if we over-oxygenate them, if we give them high amounts of oxygen, we're going to actually decrease them breathing, and then they're going to hold on to that CO2, which is the opposite of what we want to do. So we have to monitor that oxygenation very closely, so that when we are correcting this respiratory acidosis, or when we are correcting this hypoxemia, we are not over-correcting it. So that is extremely key when it comes to oxygenation. Now, key things that we want to assess whenever we are going to assess our patients. Remember that the increase in CO2 can change the patient's mental status. So we are going to do mental checks on them. We are checking for level of consciousness, decreased level of consciousness, any change in that mental status, whether it's personality changes or any of mood swings, those types of things. We want to be aware of those. Vital signs, we're looking at the tachycardia, the rate, and this can be a result of, again, the heart trying to get all of the oxygen to our vital organs. We may see tachycardia. We can be assessing our skin color and our temperature. This can be an indicator of both hypoxemia, where we don't have enough oxygen and our skin kind of turns blue because it doesn't have the oxygen it needs, or it could also be that flushed from that vasodilation. So we're kind of in those acute settings. So we're looking at both of these things to assess our patients. Now, we also want to assess the respiratory rate, because if there is a decreased rate and depth, especially in respiratory acidosis, this could lead to respiratory failure. This could mean that our condition, whatever is causing the respiratory acidosis, is actually getting worse. So we always want to monitor our respiratory rate and our depth. Lung sounds. When we are listening to our lungs, we may have diminished lung sounds because of an obstruction that might be present, or because of the muscles, like we talked about. Some of the things were muscular issues. That could be because our muscles are not actually working properly to give us good deep breaths. We could have wheezing, rhonchi, or crackles because of fluid that has actually filled the alveoli in our lungs and has impaired that gas exchange. So we're listening for those things. And then the position of the patient. Our patients need to be in Fowler's or semi-Fowler's, and this is going to help one with their lung expansion as well as help them cough anything and get that airway clearance so that they can have that gas exchange. All right, so we're going to wrap up with just a quick review of respiratory acidosis. So remember, the pH will be decreased, which it means that it's going to be less than 7.35. And this occurs because we've retained that CO2, which turns into that carbonic acid, increasing the body's acidity. Our PCO2, like I just said, is going to be above 45 because our lungs are holding on to that CO2, or for whatever reason they can't get rid of the CO2. Our bicarb is going to be within that normal range, that 22 to 26, especially in acute acidosis. Remember, because the kidneys have not had enough time to start buffering effectively. Now, when our patients are compensated, so we'll hear this term compensated, and this has to do with whether or not the kidneys have actually kicked in to try to bring that pH back to normal range. So if we are fully compensated, that means that we will have a normal pH. So it will be back within that normal range of 7.35 to 7.45. And our PCO2, it's still going to be high. It's still going to be above 45. But our bicarb now is also going to be elevated, and that's because the kidneys have started retaining that bicarb. They've increased the amount of bicarb that is now available in our body. So to be fully compensated simply just means that the kidneys kicked in to correct that respiratory acidosis, and it brought back the pH to within that normal range of 7.35 to 7.45. You may also hear the term partially compensated. And what partially compensated means is that the ABGs have started to correct. We can see them trending in this direction, but they have not fully gotten that pH back into normal range. So our pH might be just barely below that 7.35, and our bicarb may not be above the 26, but it is definitely very close to 26, like 25, and we expect for it to be moving above 26 within the next few hours and or even the next day. And so that's why we may be partially compensated, because that pH is still slightly acidotic. But we know that we are trending toward being fully compensated, and our kidneys are working to hold on to that bicarb as well as get rid of those extra hydrogens. So this is respiratory acidosis. I hope you guys have been able to understand it. When we do the live Blackboard, I will do some have ABGs for you to look at, as well as do a case study with you guys so we can kind of think through some of the things that we've talked about.